Jamal is the physician-in-chief for East Bay Kaiser, as we said. Jamal has a very good resume, as seen here. He followed me as president of California ACC, and I looked at him as the cleanup batter to handle all of the messy problems we may or may not have left at that time. So batting cleanup at this point is Jamal Rana, and welcome to the program.
Dr. Balmer, you're too kind. No, those are very big shoes to fill. And I'm actually thrilled to partner with Haiti and Right Initiative since my days at California CC. I think it's a very, very important work that's happening. So always thrilled to be back. So I'll try to be on time and just talk the big picture stuff. So next slide, please. So, the topic today is like, how do you control cardiometabolic risk factors, especially in big populations? And I was thrilled to see the data that Dr. Balmer sort of shared that over time, all systems are coming up. So this is really, really good news. It was very heartening to see all the risk factor controls that's happening. So, but, I'm here to sort of share what Kaiser has been doing for some time now and has been a leader in the past. And so glad to see that others are also doing fantastic, fantastic work. Next slide. So, policymakers and healthcare leaders are aware that despite spending twice as much per capita on health, the US leads amongst highest income countries in early mortality. So what I call it is that we do a really good job in sick care and not so much healthcare. So the way systems are set up is that you pay for fee for service, people get sick, and then you sort of get the money for treating them. And the whole idea for us is to sort of turn it around and try to prevent things from happening. And that's what we are doing here. It's sort of more value-based care. It's the right thing for the patients. And that's the only way to sustain our high GDP for the United States of America. Next slide, please. So I'm sort of thrilled and honored to share this. Kaiser Permanente provides healthcare for over 12 million patients. So our footprint is more than Northern California. Having said that, Northern California has 4.5 or 6 million patients. Southern California, 4.6 patients. So it's like 9 million are from California. So what we do is represents most of the Kaiser Permanente across the country. But I thought this would be a good chance to share that we have a big footprint, not only in California, but outside California as well. And Medicare 5 stars, 12 years in a row it's no small feat. So next slide. This is a publication that has been shared in the past. I know it's a bit dated, but again, it just shows a success story that we had. So as you could see that back in 2004, we were back down in that graph, and then over time, our HEDIS measure trended up to all the way actually peaked at 2015. And you could see that the orange line is Medicare patients and commercial, which means all ages. We did really, really fantastic work. And we have published it and shared our sort of recipe and how it's done widely. Okay, next slide. So this is another publication. Dr. Sydney is on the call. No, is on the call too. Him and I have been working very closely on many things. So I just want to shout out to him. But for this paper, what I did was we compared the things Dr. Balmer mentioned: good blood pressure control, good lipid control, good and like bad blood sugar control. So the bottom line is that as you could see that, and each one of them, Kaiser Permanente was way, way higher than among diabetes patients compared to the rest of the country in each of those things. And in this one, you can see the good lipid control. So in those times in HEDIS, the lipid control was actually LDL less than 100. So I'll talk more about that, how the goals on LDL should come back. I know there was change and things happened that we only talk about statins, but that's really old news. We need to come to 2025 now. I'm very saddened that things are kind of stuck at this whole statin adherence. There's a lot more work that needs to happen. Okay, next slide. So I know Dr. Levine is also on the call. This is the face. This is the sort of crown jewel of how Kaiser Permanente in Northern California has done the work. So these are the key elements that comes into, we call it Prevent Heart Attacks and Stroke Every Day, the FACE program. It's a registry of over almost 500,000 patients. And then those are actively being tracked by our sort of enterprise-wide system. And then there's performance feedback, there are treatment protocols, there's team-based care. So we came up with the word team-based care way before it was sort of a commonly used thing, which is the right thing to do. So it's not just the physician working alone, but it's also the pharmacist, it's the MA, it's the nurse, it's the whole team, it's the primary care, it's the cardiologist. The whole team come together with the ultimate goal of quality improvement culture. And what does that lead to? Better patient outcomes. So I think this whole sort of work flows all the way to ultimate goal of all of us that we share is better patient outcomes. Next slide. So I'm not going to read through the whole thing, but I'm just giving you sort of a taste of what it is that, for instance, every year, systematically, we see all those patients who have diabetes in our system, and we enroll them in this phase program. And similarly, we also use systematically go. So this number can change. This was just like a year ago, 2 years ago, but this is approximation. And by ASCVD, I mean both MI, heart attacks, and stroke. So stroke was not in the front and center way back, but now it is. So every year we systematically go and add this patient to our phase registry. And then there's a very, very detailed guidelines, guided sort of protocol that our like pharmacists and MA and RNs who have these panels, and they can start reaching out to the patients and take care of it. And then if there are questions, patients have questions, they can always go to the primary care physician. And if they have a question, cardiologist is always there to sort of nudge the work forward. Okay, next slide. And again, this is sort of a more deeper dive, like how it's done. I'm not going to go into too much detail, but I do want to share best practices. That there's a dashboard for hypertension registry, for instance. Then people get flagged. So, for instance, somebody is going for like I don't know, toe surgery or ankle sprain. Even then, as they walk through the door in an outpatient setting, a flag comes up for the MA that, hey, the BP is due. Can you do so that it's not a lost opportunity for anyone to get their blood pressure checked. And then they can check it. It's free of cost. And then if it's really high, the team can be paying, hey, the blood pressure is too high. Please add another medicine or talk to the patient. So this way, there's a whole culture of collaboration, and everybody feels that they all own that patient for these things. And I think this is shout out to the PharmDs team of nearly 300 across our region that diligently work with these very challenging control of diabetes patients. Okay, next slide. So cardiac rehab program, again, this is Dr. Amin is here. I mean, who's retired and was Stanford now. I mean, they did a fantastic job. We started the home-based care, virtual care even before it was a thing. And the good thing was when COVID came, we were able to sort of adapt pretty quickly. And then we use innovation and virtual thing to teach patients how it's done. And then a lot of patients like it because they don't have to drive down and especially park, and especially in big cities and all that stuff. And then it's free of cost. These patients sort of are being touched several times by this team, so that physicians are already very burnt out and busy. They don't have to sort of take it all on them. Next slide. Another big thing, we actually recently published this data as well, that we celebrated 300,000 quitters since 2014. So in a decade, we were able to smoking is one of the biggest risk factors that we know of. So California as is, it's a very high bar of low smoking in that way, it's only 9%. And the KPNC was 9.2%, just like the rest of the California, but 22-23 data shows we're down to 5.8. So as you can imagine that if something's already really low, it's really difficult to keep things going lower. So this was a lot of intentional work that was successful. And then, we worked on some analyses like, hey, if there's so much less exposure to smoking, how many lives could be saved, not only from heart attacks, but also lung disease and other chronic diseases. So 3 million lives saved, life years saved, sorry. Okay, so next slide. I'm sorry about all the photos, but this was part of the thing that came out with this things. Physical activity is very important. It's part of as Dr. Nunes mentioned, that part of the AHA, like life ideal 8 things. And then, I showed that when patients are not moving or being very sort of idle, the risk could be as bad as being a smoker. So, they call it sitting is the new smoking. So that's the thing that we always have to come back to. So yes, lifestyle is difficult, it takes time, but it's also something that we should keep reminding patients. So next
I
slide.
have one quick
Yeah,
question
go
for
ahead.
you,
Yeah,
Jamal.
yeah, go ahead.
So back on the exercise
Mm-hmm.
slide, um,
Yeah.
I remember we had another Southern California Kaiser physician talk about having exercise as another element of your electronic health record. Are you also doing that in Northern California?
Absolutely. Oh, thank you for the question. I don't want to go into too much details, but yeah, we call it vital sign. So we that's how we capture data in millions of patients. So when somebody comes in, we talk about their like blood pressure and weight and height and BMI, and then we ask about smoking in the same way we ask them about their physical activity. And we've kept the question really simple, like 30 minutes or how often you do that. So we call it the vital sign. So that's how I was able to get that data and publish it and compare with other things. So thank you. Yeah, and that's what people should be doing. It's always a reminder. I joke that anytime I have to go to a dentist, that's flossing more often. So the more questions we ask, the more people will be reminded to do that. And this is another a paper with Dr. Sydney, who's on the call, that we just looked at. Like, this other paper was how good you do in terms of risk factor control, and this is the outcome. So decline in adult deaths from heart disease and stroke, but twice as much in the same period in KP for KP members for the rest of the United States. I mean, this is just incredible. Speaks to the point of like healthcare, not sick care. Okay. Well, I'm going pretty fast, but I guess people there are a couple of other points I do want to make. So this is priceless. Fewer heart attacks, more heart attacks. So, and I do want to acknowledge that by no means this work. It's a whole system working for like decades, and then it has come to fruition at this stage. Okay, so
That's
kudos
one
to
of the best ads I've seen. Thank you. That
yeah,
really can motivate people.
yeah. No,
And I'd
I
like to
picked
see more of it on billboards and that sort of thing.
that's right. I picked with care of all that. So, and but again, in the healthcare system and systems, I mean, there's always this economic thing. It's sometimes it's business. Like, what does it all mean? So, I have no relations with the RPIH. This is one of the federal things, but it's just a slide like how like if you have a heart attack, the cost to society for heart attack is around $100,000. So the systems can really save money every time. Of course, they're saving the patient and like quality of life, everything. But there's a huge saving to our systems in terms of prevention. So next slide. So I'm doing a little bit of pivot here because I think this is very timely, and Haiti told me to just really talk about this. That there's this beautiful paper in American Journal of Preventive Cardiology. I highly recommend everybody to read it. State of the art by Dr. McOver, Shapiro, and Peter Toth. And so this is one of the slides. It's a very classic slide. That how it's log linear relation between every level of LDL you go down, your relative risk of heart disease goes down. And there are many iterations of this slide. There's a very big slide with like 30 blinded randomized controlled trials showing that. So I know it sort of breaks my heart when I'm in social media and there's naysayers. I think they're doing active harm. No one is saying if you control LDL, the whole thing will get solved. No one is saying that. But then it's a big part of it, not smoking, LDL, blood pressure, diabetes control. There's still residual risk of heart disease like Lp(a) is coming up, but that doesn't negate the fact that we should control what we can control. And there's a next slide, please. And then this is another telling thing. So you could see that we call it the cholesterol years. You know how there's a concept of smoking years. So there's a concept coming up from AHA and ACC that more high levels of LDL you're exposed to, the higher the chance of you getting a heart attack or atherosclerosis in your thing. So patients with severe hypercholesterolemia, you could see like age. So on early age, they start the threshold for ASCVD is the dotted line on top with the blue. So you could see that the severe hypercholesterolemia patients were birthed crosses that dotted line way earlier in the age. And then you can see on the far right, when people in green have lifelong low LDL-C, because genetics, lifestyle, whatnot, they actually not getting to that dotted line. So this is based on a lot of publications, but I like this this article, because it simplified the concept really well. So yeah, and then next slide, 2 more minutes. Yeah, this is again a powerful reminder that there's urgent need to reestablish LDL-C or cholesterol measures as quality metrics. I mean, we live in a world that as long as there's accountability, there's this, it's really needed. So you could see that, yes, higher density statin is the first step, but how many are truly on actually get to the goals? I mean, last 10 years, the science have moved to lipid lower therapy beyond statins, which is fantastic. But if somebody's LDL is starting at 190, you can, or 180, you can put the max statin, and then they will come to what, 100? But now we have PCSK9 inhibitors such as Repatha, we have inclisiran coming, it's here, bempedoic. So there are other things that can happen too. So yes, it was the right time for 80% to be on statin, but then you also have to make sure that they are at goal. And this is our sort of moral imperative to do that. I know I sound a bit dramatic, but it sort of really pains me. I'm a clinical cardiologist. I do hospital call all the time. These patients are coming in and their LDL testing is not being done because it's not part of the HEDIS measure, quality measures. It's been 5 years since they were updated by ACCHA, and we are sort of clinical inertia. And I really, really hope somebody from HEDIS and quality measures are listening to us and come up with the science that we should be doing right now. Okay, I think
So
this
we
is my,
can slow down
yeah.
just a little bit,
Yeah, sure.
Jamal. Let's go back to that slide. Let's back up one. And I just want to say that we would not have achieved what we achieved behind us in the graph behind me of reducing across San Diego acute myocardial infarctions if we had not said all adults should have their LDL less than 100. That's what we were teaching in that room. Instead of using a risk calculator, let's just get everybody under 100. And look how quickly you see the acute myocardial infarction hospitalizations coming down. And I'm not going to show other data, but the mortality graphs are, parallel this exactly. So it is, we stood up in 2014 when NCQA announced that they were pulling the LDL 100 target. I stood up and I said, that is going to kill people. And what have we seen?
Yes,
We've
right.
seen the death rate go up since they switched that. So it's time, over time, that it switches back. We've been advocating with the federal government, with the state government, with NCQA, and I think all of us need to link arms and focus on getting this back into a very financially incentivized metric, because it will save lives. So I'm just affirming your call to action.
Yes, no, thank you. I didn't know that you guys stepped up. But this is, even the data that I showed you earlier was, if you could do it back in 2000s, why such a resistance to this thing, especially when this could potentially save money and life and everything, and when we have options. And as I said, unless we're testing the LDL levels, we're not making part of our practice. People sometimes are not adherent, or they say they take it, they will refill it, but they want to take it. So I don't know what else to say, but we keep trying, and that's what we should be doing, And I practice it on myself, on my patients, but we do need support to make it like a quality measure, so the systems can also be, aggressively do that. Okay, I stayed in time so people don't get bored. So yes, go ahead.
Oh,
Somebody else
this is
comment.
Eleanor. Hattie
Yeah.
and Jamal, can I make one comment?
Sure.
Oh, okay.
Absolutely.
Yeah. Well, first of all, Jamal, I'm so proud of all the work you've done and that you've continued everything since I left 8 years ago, because that was, of course, one of my concerns after spending decades building this stuff.
You did, yes.
So I'm just thrilled that you've continued. On Phase on a Page, which is that very detailed slide that Jamal showed, I wanted to put out a pitch that in Kaiser Permanente, we basically even out the social determinants of health because all our ethnicities,
Yes.
which are so diverse across the organization, have similar reductions in heart attack and stroke. And we don't have those as much disparity there. But something that I've discovered in the last 5 years is that for East Asians, not South Asians, not Filipinos, there is a Chinese dose of statin where the max atorvastatin is 40 milligrams and the max rosuvastatin is 20 milligrams. And then once you get to that max dose for East Asians, which is wherever the Chinese diaspora went, you add ezetimibe 10. So you might just Google the Chinese dose of statins. You'll see all the papers right there. And that might benefit from being added to phase on a page because our Bay Area.
Yeah, 20%. 20%.
Yes, you got it.
Biggest in the country, yeah.
Yes, yes. And not South Asians, not Filipinos, but basically Chinese, Japanese, Koreans, Malaysia, wherever the Chinese diaspora went, including here, the United States. So just as an addition, because I know when I first started making the phase on a page with Adria Beaver, also now retired, you know, it was quite simple and I saw how intensive it was. That's it. Thanks.
Okay, thank you.